Assalamu alaikum wa rahmatullahi wa barakatuh. Our subject today is about the management of anemia in pregnancy. So the outlines will be introduction, definition, classification, what are the normal pregnancy changes that lead to anemia, the clinical features, and iron deficiency anemia, folate deficiency, and vitamin B12 deficiency, and the summary. So what is the definition of anemia in pregnancy? Anemia is a pathological condition in which the oxygen carrying capacity of red blood cell is insufficient to meet the body's need. That's why most of the women with anemia, they will have shortness of breath, dizziness because of less oxygen carrying capacity of red blood cell. Based on hemoglobin concentration in first trimester, anemia will be defined less than 11 if hemoglobin less than 11 in second and third trimester, if hemoglobin less than 10.5 in postpartum less than 10 gram per deciliter. So the classification either physiological or pathological. There are also classification is due to deficiency, due to iron deficiency, folate deficiency, vitamin B12 deficiency, hereditary, either thalassemia or sickle cell disease or hemolytic anemia, hemorrhagic due to antepartum hemorrhage, postpartum hemorrhage, and hookworm, bone marrow insufficiency like aplastic anemia, infection like malaria and TB, chronic renal disease, and neoplasm. All this will lead to anemia. So what are the normal pregnancy changes that lead to increased risk of anemia? In pregnancy, there's increased plasma volume 50%. Also, there's increase in red blood cell around 25%. These together will lead to what's called hemodilution, in which there will be full in hemoglobin, hematocrit, and red blood cell. So it's very important for any pregnant women, especially sickle cell and thalassemia, if hemoglobin less than 9 or 8, to not give iron immediately unless measure the ferritin level, because sometimes hemodilutional is the causes of anemia in pregnancy. What about MCV? Will be increased in pregnancy. MCHC is stable. Serum iron and ferritin itself will be reduced in pregnancy. Total iron binding capacity will be increased. The iron requirement in pregnancy will be increased from 2.5 milligram per day to 6.6 milligram per day from first trimester to third trimester. That's why if you know that we are giving some time in first trimester, if normal hemoglobin will give only folic acid. After first trimester, we'll be giving FeFol because there is increase the iron requirement in second and third trimester. Iron absorption will be increased. Folate requirement will be also increased. Vitamin B12 stores has no effect. Cobalamin level will be decreased. So these are the normal pregnancy changes that happen. Hemoglobin in non-pregnant 12 to 15, in pregnant 11 to 15. Iron deficiency or anemia is less than 10.5 in second and third trimester, less than 11 in first trimester, as we discussed it earlier in the first slide. What about ferritin? Ferritin normal in non-pregnant 15 to 300 will be decreased in pregnancy. So less than 12 or less than 15, I will consider the need for iron supplement, even if sickle cell anemia and thalassemia. Again, iron requirement in pregnancy, as we discussed earlier, it will be increased with advanced pregnancy. What are the clinical features of anemia? This is very common, and I'm sure everyone know about it. Sometimes asymptomatic. Many patients, they come has no sign and symptom, but when you measure their hemoglobin, you find 7. Sometimes dizziness, even with hemoglobin 9, 9.5. Palpitation, very common in pregnancy because increased cardiovascular heart rate, and also anemia is one of the causes of palpitation in pregnancy. Lethargy, weakness, pallor, fatigue, shortness of breath, as we say, because reduced oxygen capacity. Also cholinicia, angular stomatitis, and atrophic glossitis. So in pregnancy, we should do screening for anemia is very important. We will do full blood count at booking and 28. And also here in MOH, we are doing at 36. This is according to RCOG guideline. In multiple pregnancy, in a twin, it's very important to measure also the level of hemoglobin CBC at 2024. So any pregnant women, full blood count will do at booking 28 and 36 according to RCOG is booking at 28 according to MOH booking 28, 36. But it's very important in a twin to repeat the CBC at 2024. You can do it also with OGDT if the patient is not diabetic. Postpartum care, yes, of course, after delivery, also all the women attending the postnatal clinic should be tested for the level of hemoglobin at 6 weeks. All women with low hemoglobin in the postpartum period should offer iron supplementation for 3 to 6 months. Iron deficiency anemia, as we say, there are iron deficiency anemia or folic acid anemia or B12 anemia. So iron deficiency is the most common causes of iron deficiency anemia, most common causes of anemia in pregnancy, because here the demand exceeds supply. So there will be significant iron demand, limited iron absorption, and iron store use, iron stores depleted. All these will lead to iron deficiency anemia. So the causes of iron deficiency, as we say again, either chronic blood loss or decreased iron intake, especially in vegan and veg patients, or decreased iron absorption, especially in celiac disease or atrophic gastritis, or sometimes those patients who are taking proton pump inhibitor with the iron, this will reduce the absorption of iron. Helicobacter bacteria also lead to decreased iron absorption. Sometimes increased demand, pregnancy itself can lead to increased demand and menstrual loss, blood donation. So these are the causes of iron deficiency anemia. What are the consequences of anemia? There will be impaired function of iron-dependent enzyme, alternation muscle function, neurotransmitter activity, and epithelial changes. There will be preterm delivery, IUGR. There will be risk of infection, increased risk of medical intervention during labor. There will be increased postpartum blood loss and postpartum hemorrhage. Also, anemia itself can lead to postpartum depression. So it's very important to treat anemia in pregnancy to avoid all these consequences as a preterm delivery, IUGR, infection, postpartum hemorrhage, and postpartum depression. This is from the manual Antenatal Care Ministry of Health, Oman. As we see here, if it is mild anemia, defined is less than 11 to 10. So here you can give people capsule, ferrous sulfate 150 milligram plus folic acid 400 microgram daily doses. And we will monitor every 4 weeks in order to see compliance and the response to this iron. So for mild anemia, you will give VFOL and measure hemoglobin after 4 weeks. And of course, health education is very important, and always for anemia, as any medical disease like hypertension, diabetic, please refer to dietitian. What about if less than 9.9 to 7? This is called moderate. In moderate, if according to the gestational age, if it is gestational age less than 34, you can give one tablet of ferrous sulfate, TID, and monitor hemoglobin every 4 weeks. And also health education and refer to dietitian. But if the gestational age less than 34 weeks, and investigate for other causes of anemia and will treat accordingly. If not respond after 1 month, then in this case, you have to refer to secondary care if gestation more than 34 weeks, or if there is no response after 4 weeks to medication. However, we have iron IV sometime. So if the gestational age is more than 34, we prefer to give here iron IV because can manage anemia quickly in this gestational age. But if the patient is less than 7 to 4 severe anemia, of course, here you must refer as emergency because here need blood transfusion. So again, if mild, give FeFOL and measure after 4 weeks. If no response, just do further investigation to rule out why there is no response. And of course, you should refer to dietitian. If moderate up to 7, you can give ferrous sulfate TID and measure after 4 weeks. But if 34-week gestational age and above, you can give iron IV. But if severe, less than 7, it's preferred to send to hospital for blood transfusion. So here, the treatment, oral iron is preferable. The iron tablet should be taken 1 hour before meal with source of vitamin C in order to help in absorption. In case of drug intolerance, it can be taken with meal. So the first line is oral iron replacement, which is ferrous sulfate. And if you give ferrous sulfate within 2 weeks, there will be increase in hemoglobin around 0.8 gram per week. That's why we will say we'll measure it after 4 weeks. There will be response to the iron tablet. The result are better observed. Vitamin C help in absorption as we mentioned, but the problem is GIT side effect. That's why if fail oral tablet or the patient couldn't tolerate the tablet, we can give parenteral iron, but please should be avoided in first trimester. And they found that the iron, IV iron, can help and increase the hemoglobin by 2 grams per deciliter. Just a note that FeFOL, the iron is 150 milligram with 45 milligram elemental iron, ferrous sulfate 200 milligram, 65 milligram elemental iron, ferric gluconate 125 milligram, iron sucrose 200 milligram per deciliter, one packed cell 250 mil can increase 60% hematocrit. So again, for mild to moderate, we can give iron tablet. If no response, we can give iron IV. But again, please avoid iron IV in first trimester. Regarding blood transfusion, also they found that 1 unit increased hemoglobin by 1 gram per deciliter, and we say blood transfusion to be given for severe iron anemia. What about erythropoietin stimulating agent, which is recombinant human erythropoietin analog? Usually this is in chronic renal failure, Jehovah's Witness, pregnant renal patient. So it is not available in primary healthcare. So we'll focus on 2 things, either a tablet for mild and moderate, and if moderate and more than 34, we prefer to give iron IV. If severe, refer for to the secondary institute for blood transfusion. What are the prevention and the prophylaxis? Of course, good balanced diet, health education. That's why we should refer all the anemic patient, please, to dietitian, because they will counsel the patient what is the important food that contain and can increase the iron level in their blood. So again, we say it's very important to refer dietitian because sometimes we do not have time to counsel her that there are some important points, like example, to not consume milk, tea, or coffee with food, or within 2 hours of taking iron tablet, to not take antacid with meal, or within 2 hours of taking iron tablet. So there are some important points that we have to counsel the patient while taking their food or taking their iron tablet. So again, I'm focusing on the dietitian because it's very important because most of the anemia is due to an improper diet. So it's better to avoid antacid. They found that it's increase the anemia. And also the tea, the coffee, the chocolate, all these can increase anemia. And regarding the folate deficiency, they found that also there's increase in demand as increased cell replication. So it's very important to give folic acid at least 1 month before a pregnancy and continue first 3 months. Because if there's folate deficiency, this will lead to neural tube defect and fatigue, breathlessness, palpitation, headache, and irritability. And the treatment is to give folic acid 5 milligrams per day. And here for only the pregnant women only first 3 months, but for some hemolytic anemia, sickle cell disease anemia, sometimes for epilepsy on antiepileptic medication, we give whole pregnancy. What about vitamin B12 deficiency? Sometimes many patients, they have numbness, they have fatigue, and we measure the vitamin B12, we found there's deficiency. So even though it's rare in pregnancy, and most of these patients will be infertility, but sometimes it's happened, especially those have patients who have history of gastrectomy, Crohn, vegan, anti-acid long-term. So always you found they are pale skin, fatigue, sore tongue, mouth ulcer, pin and needle sensation at their hands, ataxia, dizziness, disturbed vision, and depression. And sometimes when you measure their hemoglobin, you find it's normal, but this is due to vitamin B12 deficiency, the same sign and symptom of anemia. So the management is here to give injection vitamin B12. And these are the references of my lecture. Thank you very much.